right, so about the last topic we're going to be learning about in this class is actually going to veer away from classic experimental designs. But I think this is, though it's not even in our book, I'm having to pull from other sources besides our book for this. I think it's really important to touch on this because, especially in the era of big data, hardly any of our big data is going to be experimental. Experimental studies still play a huge role in data science. I mean, with everything from A/B testing to the use of experiments within the research sciences and everything. But you're going to be dealing with a lot of data that just for either ethical or logistical considerations, you are not able to randomly allocate treatment subjects to the groups and or participants to the treatment groups, I should have said. And so this becomes a really important method. And there's a lot of quasi-experimental methods out there. I'm going to focus in on the one that I think is most accessible, but also the most applicable in a lot of situations, because it's based upon the linear model framework that we've been, situated in this whole semester. And then it's just, you're going to see it most commonly in the applied literature as well. So when you work in, say, an interdisciplinary team, this is something I use once a month with teams on campus, this kind of idea, especially with a lot of the educational data I look at, which is almost always observational. Okay, so next slide. The outline of this is we're going to just talk about a little bit about the motivation. Why in the world do we need to understand what propensity score is, what the score is, how to estimate it. There's actually a few updates to the estimation I'll mention, how you match based upon the score, how you stratify. I like stratification personally. I think there's a lot of strengths to that approach. We'll talk about that perhaps a little when we get to it. I'm going to talk about an R package and then some SAS. I know we didn't do SAS at all in this course, but SAS actually has a little bit better facilities, I think. I don't know. R does too. A couple conclusions and then the literature if you want to go read more. Okay. So first, an anecdote about why quasi-experimental designs like propensity score matching or propensity score modeling, I should say, is needed. This, by the way, this is from a lecture from a long time ago that I heard from a woman at Vanderbilt School of Medicine. And I always really liked her example. And so I took this from her. Two heart surgeons walk into a room. The first heart surgeon says, "Man, I just finished my 100th heart surgery." The second surgeon replies, "Oh yeah, I finished my 100th heart surgery last week. I bet I'm a better surgeon than you. How many of your patients died within the past 3 months of surgery?" Within 3 months of surgery. I said that wrong. "Only 10 of my patients died." The first surgeon smugly responds, "Only 5 of mine died, so I must be the better surgeon." The second surgeon says, "But my patients were probably older and had higher risk than your patients." Okay, so we can all understand this situation, and we can understand why perhaps the first surgeon might be smug, but then we can also understand the hesitance of the second surgeon to admit that the first surgeon was the better surgeon. And it's not an illegitimate, this is not just excuse making. This is a really legitimate point the second surgeon makes. So the other thing too is that, this is a scenario where we would not presumably ever have experimental data, nor would we really want to. Think about the ethical considerations there. So this is a perfect example where a statistician or data scientist could say, you know what, I think some sort of propensity score method is going to be useful here to help decide who's the best surgeon. Not that I don't know that I would get involved personally. But the issue comes down to this. When you're comparing things like those surgeons' mortality rates, are you comparing apples to apples or are you comparing apples to oranges? There may be some important differences in the patient characteristics between the two groups. I've seen this a lot in educational interventions where they're wanting to say, oh, our curriculum, look at all of our great student outcomes. And I'm sitting there going, yeah, but you started with great students. And the schools using the other curriculum don't start with the same students. See it a lot in this context, health context. You can, almost any area, you're going to find places where people are trying to compare apples to oranges. And that's not correct. Okay, we want to show the difference, that difference in the outcome is solely attributable or mostly attributable to that difference in the treatment and not some other confounding factor such as the condition of the patient, the climate of the hospital, the conditions of the hospital, etc., etc. In a school setting, the student characteristics or the setting of the school, the resources of the school, etc. Okay, that way we're not comparing the apples to oranges, because really if you say, oh yeah, surgeon 1 is better than surgeon 2, you may just be really effectively saying surgeon 1 gets easier or healthier patients than surgeon 2, and that's really the difference for their outcome. So these non-randomized comparisons should make us skeptical and should make us wonder, is this really a good comparison, or is it not something that's reasonable to compare straightforwardly? And we should recognize this as well, that sometimes it's either not possible or it's just really unethical to assign patients to different treatments. I wish we could use more like random assignment. I've advocated that in a lot of educational studies, but even there, when you've got, I think it's okay ethically if you have two good options in terms of curriculum to see small minor differences in learning outcomes or something. However, in medical situations, it would probably hardly ever be reasonable. The only time I've used experimental designs that are reasonable is when I've worked with a surgeon in town, and he knew both of these methods, or the devices he used in his surgeries were both very good. It's just that one was like a quarter of the cost of the other, but he wanted to have the evidence from an experimental design to say, really, we should not be using this one that's so much more costly to the patient and to the hospital when this other one's just as good. And that's a reasonable place to use random assignment. Okay, so purpose of the propensity scores. This is going to allow us to make fair comparisons, apples to apples, even when we're dealing with observational data, non-randomized conditions. This is going to provide us a way to summarize the covariate about the treatment selection at a scalar value. And it's going to give us the ability to adjust the differences between the study via a study design difference. So you can kind of replicate an experimental design via the process of matching, or you can just adjust in the estimation phase, which is the stratification. And there's a new article I recently came across when I was trying to decide between matching and stratification recently. And they gave some really good guidelines, because there are some cases where you really should stratify and some cases where you should match. I can add that as a reference at the end. Analysis limitations. You can't have too many events. For example, your treatment. If you have, most of the time people have like a treatment and control, honestly. I've done this on situations where there were 4 and 3, but never more than that. I think less than 10 is a good guideline. That came from the Herald article, I believe, or maybe, I don't remember. Estimated coefficients may be biased or incorrect. If you really want to dig down into that, there's some more recent works than Herald. Frank Herald, that 1985 is an excellent resource. It's old, but I still use it. Okay, Publications with the term propensity score. This is up to recent, not very recent. I'm sorry, this was not updated at all. But you can see there's been a rise in its popularity. It was not done very much early on, and now it's just even more popular than this. So let's get into some of the mechanics here. We have treatment groups. Usually it's like, you really think of it as like a treatment and control, okay? So E plus would be those who get the treatment. E minus would be those without it. Now you can generalize this to more levels of your treatment. Sometimes you may have 3 or 4 levels to your treatment, and it's possible to do that. This is just very general introduction. Then you have your disease outcome. D plus is the group with the disease outcome. D minus is those without the disease outcome. Or it could be like a, it doesn't really have to be a disease outcome. This is the notation used from the paper. It could be a condition, or it could be death or no death. I guess that is a disease outcome. Or it could be reaching a certain state, okay? So it could be all kinds of things, not just having a disease or not having a disease. Then we finally get the propensity score. For an individual, a propensity score is simply that conditional probability of being treated, E plus, given the individual covariates. So PS is that conditional probability that you get the treatment exposure given a certain group of covariates. And what are those covariates? They are typically very specifically chosen because they are ones that are known to be associated with that exposure of interest, the E group, the treatment group. Okay, so for example, if I'm designing a propensity score matching algorithm for use in an educational study, and my E group, my treatment group, is use of a certain new curriculum, that would be E plus, and E minus would be the old standard curriculum. Perhaps I know that the higher SES schools are getting the new curriculum. Perhaps I know that the schools that are in a certain area of town are getting the new curriculum. Perhaps I know that students with certain characteristics or certain backgrounds are getting the new curriculum. So all those pieces of information that I know are associated with getting the new curriculum would go in as my covariates in that estimation of that conditional probability. Okay. In a disease setting, maybe the treatment is something like aspirin for heart attack. Maybe you know that men of a certain, ethnicity and of a certain age are the ones least likely to take aspirin. So maybe you put in male, age, and ethnicity as your covariates in that case. Okay. So I just talked a lot about identifying those covariates, those confounders. If uncertain whether a covariate is a confounder, just include it unless you have trouble with the algorithm converging, which can happen. And then if you don't think, but I really go through and do an association analysis. I like to do that. Be informed about your choice. So model E plus is typically dichotomous, but like I mentioned, it can be multiple levels. Is a function of those covariates using that entire cohort, all the research participants, all the observational study. I'm going to stop here and do a second set.